Welcome back to the deep dive. We are doing things a bit differently today because we are reacting to some really big news.
It's definitely breaking news.
Yeah, it's a Thursday, February 5th, 2026, and a study has literally just dropped in the New England Journal of Medicine. And I think we're going to look back on this one. This feels like a turning point in cardiology.
It really does. I mean, the NEJM, they don't just publish anything. And this trial in particular, well, it's been on a lot of people's radar for a while now.
So we're talking about a new drug. It's called Enlicitide. But really what we're talking about is a very specific group of people who've been, fighting a battle against their own genetics.
And that's the real heart of the story. It's a condition called heterozygous familial hypercholesterolemia, or HEF for short.
Right. Yes.
And while our name is a mouthful, the reality for these patients is it's incredibly stark.
So the mission for this deep dive is to unpack this new phase 3 trial. We need to figure out, does this new oral treatment actually work for people who have pretty much maxed out all their other options?
Is it safe?
Is it safe? And just how much does it move the needle on cholesterol numbers that, for them, seem almost impossible to bring down?
And that moving the needle part, that is the crucial context here, because the patient profile we're looking at today, it represents one of the most difficult challenges in modern heart health.
Okay, so let's start right there. Let's unpack who these people are. Familial hypercholesterolemia. I think most of us hear high cholesterol, and we think, okay, cut back on the cheeseburgers, maybe hit the gym.
Right, and that's the common misconception. Most high cholesterol is driven by lifestyle, maybe age. It sort of creeps up on you. But HeFH is genetic. It is a fundamental mechanical failure in how the body processes cholesterol.
So you have it from day one.
From birth. Imagine a baby being born with the cholesterol levels of, say, an unhealthy 50-year-old, and that level just stays high their entire life.
That reminds me of this concept you've talked about before, the idea of cholesterol years.
Exactly. It's like pack years for a smoker. It's not just about how high your number is today. It's about how many decades your arteries have been, soaking in that high cholesterol environment.
So a 40-year-old with HeFH has the vascular age of someone much, much older.
That's it. So their risk for heart attack, for stroke, for plaque buildup, it's just astronomical compared to the general population. And that's why these patients are usually treated so aggressively.
Which brings us to the people in this study. This wasn't some small experiment. It was a big global effort, 303 people across 59 sites in 17 countries.
A truly international data set, yeah.
And looking at their stats, these weren't people who were ignoring their health, they were fighting.
Oh, they were doing everything right. 100% of them were already on statins. And we're not talking low doses. Over 81% were on high-intensity statin therapy, the max doses.
And on top of that, nearly 2/3 of them were also taking another drug, ezetimibe.
Right. So for anyone listening, statins stop your liver from making cholesterol. Ezetimibe stops your gut from absorbing it. So they're blocking production and they're blocking intake. They are hitting it with the two different hammers.
And yet, here's the kicker. Despite all of that, what was their starting LDL level? Their bad cholesterol.
The mean LDL-C was still 119 milligrams per deciliter.
119.
Which, for this kind of high-risk patient, is just dangerously high.
Put that in context for us. Where should they be?
Well, the guidelines say if you have this condition, you really want to be under 70. If you've already had a heart attack, the target is often under 55. So sitting at 119, you're double where you need to be.
That has to be just unbelievably frustrating. You're taking your pills, you're doing everything right, and your doctor still says it's not enough.
That is the very definition of the treatment gap. And until pretty recently, the only way to bridge that gap was with a third type of drug, a PCSK9 inhibitor. But up until now, those have been injections.
And nobody loves giving themselves a shot.
It's a barrier. There's the cost, the storage, just the idea of needles. It really limits who gets treated.
So, enter Enlicitide. The study calls it an oral PCSK9 inhibitor. Before we get to the results, let's do a quick science class. What is PCSK9 and why do we want to block it?
Okay, so think of your liver as a recycling center for cholesterol. On the surface of your liver cells, you have these little catcher's mitts. They're called LDL receptors. They reach out, grab bad cholesterol from your blood, and pull it inside to be destroyed.
So more MITs means less cholesterol floating around.
Exactly. Now, PCSK9 is this protein your body makes that, and this is the annoying part, it finds those MITs and destroys them. It basically melts the catcher's MITs.
So if my body makes a lot of PCSK9, I have fewer MITs, and the bad cholesterol just keeps circulating.
Precisely. So the goal of this entire class of drugs is to basically handcuff the PCSK9. You block the PCSK9, the liver can regenerate its MITs, and suddenly you're pulling cholesterol out of the blood at a massive rate.
And we know this works. We have injectable drugs that do this. But Enlicitide is a pill. Why has that been so hard to make?
That is a great question. It comes down to chemistry. The injectables are monoclonal antibodies. They're these huge, complex biological things. If you swallowed one, your stomach acid would just digest it like a piece of chicken. It would never get into your blood.
So you have to inject it to bypass the stomach.
Right. But enlicitide is what we call a small molecule. It's a synthetic chemical designed in a lab that's tiny and stable enough to survive the stomach, get absorbed, and still go find that PCSK9 protein and block it.
That sounds like a huge engineering challenge.
It's been called the holy grail of lipid chemistry. It is notoriously difficult to do, but that's what this drug claims to be.
A 20-milligram tablet, once a day.
Just another pill in the morning with your statin. No needles, no hassle.
Okay, so the theory is perfect. But let's see if the reality matches up. How did they test this thing?
It was a gold standard trial, randomized, double-blind, placebo-controlled. They took those 303 patients and split them 2-to-1. So 202 people got enlicitide and 101 got a placebo, a sugar pill.
And they followed them for a full year.
52 weeks. This is fresh, robust data.
Let's get to it. The big reveal. The primary goal was to see the LDL reduction at week 24. So 6 months in, what happened?
Okay, remember, they started at 119. After 6 months on enlicitide, their LDL levels just collapsed. A drop of 58.2%.
58.2.
Nearly 60%.
And I have to say it again, that's on top of the high-intensity statins they were already taking.
Correct. This is an additive effect. We're not comparing it to nothing. It's statin plus enlicitide versus statin alone.
What about the placebo group?
Theirs actually went up slightly by about 2.6%.
Why does that happen?
It really just shows the nature of the disease. Without that extra drug, the body is always fighting to get back to its high genetic set point. It shows that even with statins, these patients are just trying to hold the line.
So when you compare the two groups, the total difference is?
A staggering negative 59.4%.
Wow. So if you take someone who's at 119 and you drop them by 60%, where does that put them?
You're now down around 48, maybe 50 mg/dL. That puts them squarely in that optimal safety zone. They go from high risk to well-controlled just by adding one pill.
And the p-value?
Less than 0.01. Highly statistically significant. There's basically zero chance this was a fluke.
But the other thing is always durability. You know, sometimes a drug works great for a few months and then the body adapts. Did that happen?
So that's why they go for a full year. So they checked again at 52 weeks. The enlicitide group was still down 55.3%.
So it held steady.
Very steady. And what's interesting is the placebo group had drifted up even more by then. So the total gap between the drug and the placebo actually widened to over 60% by the end of the year.
Wow. So the drug kept working, and the untreated group just got a little bit worse over time.
It really proves the mechanism is durable. This is not a temporary fix.
Now, LDL is the headline, but it's not the whole story. This study looked at other markers, too. Let's talk about ApoB.
Apolipoprotein B.
I feel like I hear more and more about ApoB. Why is it so important?
Okay, so think of it this way. LDL-C, the standard number, measures the weight of cholesterol in your blood, but ApoB measures the actual number of particles.
Okay.
It's like LDL-C tells you the total weight of cars on a highway. ApoB tells you exactly how many cars are on the road. And it turns out the number of cars, the number of particles, is a much better predictor of a traffic jam in your arteries.
So did Enlicitide clear the highway?
It did. ApoB dropped by over 48%, again, compared to a slight rise in the placebo group. It's just so consistent.
Okay, but there's one more I want to talk about, the one that's always so stubborn. Lipoprotein, or Lp(a).
Yes, the genetic troublemaker.
So what is it and why is it so bad?
Imagine a normal bad cholesterol particle. Now imagine it has this extra sticky protein tail attached to it, like a little Velcro hook. Yeah, this tail makes the particle incredibly inflammatory and prone to clotting. It's a double threat. And the worst part is, your level of Lpa is almost entirely set by your genes.
And statins don't work on it?
Statins do basically nothing for it. Diet, exercise, they don't touch it. We've had almost no tools to lower it.
So what did this new pill do?
This was a really pleasant surprise in the trial. Enlicitide reduced LPA by a median of about 25%,
25%.
compared to basically zero change in the placebo group.
Now, is 25% a big deal? I mean, compared to a 60% drop in LDL.
For LPA, 25% is very significant because you have to remember, this is a risk factor we previously couldn't treat. So if you lower this untouchable risk by a quarter, while you're also crushing LDL and ApoB by half, you are profoundly changing the risk profile of that patient.
It's like a triple threat defense.
Exactly. And you're doing it all with a pill.
Okay, the efficacy is undeniable. The numbers are just. They speak for themselves. But there's always a but. The safety, did people feel terrible taking this?
As you should be. I mean, a drug has to be tolerable. High cholesterol is a silent condition. You don't feel it. But you definitely feel side effects.
Right.
And this is where the news is just as good. The safety profile was remarkably clean. The paper says the incidence of adverse events was similar between the drug group and the placebo group.
Similar is the key word.
It's everything. It means people taking the drug didn't report more headaches or muscle aches than the people taking a sugar pill.
What about serious problems?
Also similar. And maybe most importantly, they looked at how many people quit the study because of side effects. The rates were low and, again, similar in both groups.
So, statistically speaking, taking Enlicitide felt about the same as taking a placebo.
That's the takeaway. The authors concluded it was well tolerated. And that's really encouraging because we already know the injectable versions of these drugs are very safe. It seems the mechanism itself is just very clean.
Okay, so let's zoom out. We have a pill. It works as well as the injections. It appears to be very safe. Why does this matter so much?
I think it matters because it represents the democratization of advanced lipid therapy.
What do you mean by that?
Well, right now, getting an injectable PCSK9 inhibitor can be a real battle. It's a specialty drug, it's expensive, insurance companies put up hurdles. The patient has to be willing to do the injection. It's reserved for the worst of the worst cases.
The break glass in case of emergency option.
Exactly. But a pill changes the whole calculation. It's easier to make, easier to distribute, and infinitely easier for a patient to take. It moves this powerful mechanism from a last resort to potentially a standard part of the toolkit.
I can see a future where a doctor just says, okay, your LDL is still too high on a statin, so we'll just add this pill. No big drama.
That is the concept people are calling triple oral therapy.
Tell me about that.
You take a statin to stop cholesterol production, you take azetamibe to stop absorption,
Yep.
and you take Enlicitide to boost recycling. 3 mechanisms, 3 pills that could bring almost anyone's LDL down to rock bottom levels no matter what their genetics are.
That feels like a total paradigm shift. From managing the disease to maybe eradicating the risk factor.
If you can keep someone's LDL at 40 or 50 their whole life, atherosclerosis, as we know, it just doesn't really happen. If we can do that with just pills, we could change the entire trajectory of heart disease.
It's just amazing to think about how far we've come. I remember reading about treatments for HeFH 20 years ago, things like LDL apheresis.
Which is basically dialysis for cholesterol. You had to go to a clinic for hours every week and have your blood filtered by a machine.
And now we're talking about a pill you take with breakfast.
It's a revolution in convenience, and convenience drives compliance, and compliance is what saves lives.
So to synthesize this for everyone listening, Enlicitide. It's a new oral pill. In a huge global study, it cut bad cholesterol by 60% on top of maxed out statins. It also hit other key risk factors like ApoB and the really tricky LPA. And it did it all with a safety profile that looked just like a sugar pill.
High efficacy, high convenience, clean safety. Yeah, it checks every single box.
It's just a really compelling package. And it leaves me with this one last thought.
What's that?
You know, we spend so much time talking about gene editing, CRISPR, rewriting our DNA to fix these genetic flaws. And that is the future, I get it. But this study reminds me that sometimes you don't need to rewrite the code.
You just need to patch the software.
Exactly. We've got a genetic defect here, a broken recycling system, but we found a small, simple chemical key that just bypasses the problem. It fixes the output without ever touching the DNA itself.
That's a really fascinating way to put it.
It makes me wonder how many other genetic diseases we're going to solve. Not with some futuristic gene therapy, but just by finding the right small molecule to swallow with our morning coffee.
The era of oral genetic management, it is definitely something to think about. If you can chemically correct the consequence of a bad gene, Maybe you don't always need to fix the gene itself.
Something to chew on? We'll be keeping a very close eye on Enlicitide. Thanks for listening to the Deep Dive.
My pleasure.
See you next time.